Hello and welcome back to the Injury Podcast. I am your host, Dr. Craig Selinger, chiropractic physician. Today we have a great episode. We have a board certified neurosurgeon in the studio. Great. You don't want to miss this episode. We have Dr. Neelan here, and we also have another guest as well from SETA Orthopedic Group, Alexa, and she is also going to be on the show as well, offering a unique patient experience and patient advocate experience because she's got a lot of experience in the industry. Okay, so Doc, thank you so much for being here, Dr. Neelan. I really appreciate it.
My pleasure.
So before the show, I went through and I reviewed your bio. And I got to tell you, it was over 2 pages long, and you've been trained in some of the most prestigious universities in the world: Stanford, Yale, Duke, and Cambridge. I felt bad. I felt like a total underachiever. But it's amazing. Do you have any siblings, any younger siblings?
I do have a younger sister, yes.
Oh my God. Like, I mean, it would be great to have you as an older brother, but very, very difficult and hard to follow. The bar would be set so high. I mean, I don't know.
Is she a rocket scientist?
No, she's a judge, and she became a judge before I completed my neurosurgical training, so.
Okay, awesome. Well, that's great. So thank you again for coming in today. And we're going to be talking today about neurosurgery. Before we get into it, what is a neurosurgeon for the people out there that don't know? Orthopedic surgeon, neurosurgeon. What does a neurosurgeon primarily do?
So a neurosurgeon treats conditions surgically of the brain and spine. So that ranges anywhere from brain tumors, traumatic brain injuries requiring surgical intervention, traumatic spine injuries, degenerative spine disease, spinal tumors, and also vascular diseases of the brain and spine. That's using either open surgical techniques or endovascular techniques. There's also functional neurosurgery. It's becoming a really big field. Functional neurosurgery treating diseases such as movement disorders, Parkinson's disease that are all refractory to medication. So it's a wide variety. Spinal cord stimulators. We treat pain, cancer pain. Stereotactic radiosurgery, which I'm also trained in, which is non-invasive surgery using focused radiation to treat tumors, trigeminal neuralgia, pain conditions, even psychiatric conditions as well.
Wow.
So a whole gamut of procedures.
Wow.
A whole gamut of patients.
Okay, wow, that's a lot. So what made you or inspired you to become a neurosurgeon and do what you do?
So when I went to medical school, I actually wasn't even thinking about going into neurosurgery, but I became fascinated with the brain during my preclinical years. So the preclinical years in medical school are when you're taking basic science courses and courses about human disease. And so I became fascinated with the brain at that time. And then I kind of was, started reading about the specialties that deal with the brain. And I looked at neurology and neurosurgery. And I always thought that I wanted to work with my hands. And so neurosurgery, I was fascinated by a field you could intervene on brain conditions and spine conditions using surgical techniques. And so this is what kind of pushed me towards neurosurgery.
Wow. And from it's such a broad field too, because somebody might need neurosurgery because of a tumor in the brain, right?
Yeah.
Or in the spine. But somebody also might need surgery because of trauma. And I read a little bit in your bio that you have this trauma experience as well, which is interesting. So within neurosurgery, I guess there are subspecialties. Is that correct?
Yes, so there's subspecialties. There's pediatric neurosurgery. There's spine neurosurgeons who focus on complex spine and also do minimally invasive spine. Tumor neurosurgeons, skull-based neurosurgeons, so neurosurgeons who operate at the base of the skull, also use endoscopic techniques, removing tumors by going up the nose. So lots of different things. Endovascular neurosurgeons who just concentrate on vascular diseases of the brain, so like clipping aneurysms, treating vascular malformations.
That's awesome. So, do you remember any any particular cases that you were introduced with where you were like, that's it, this is the kind of work I want? Maybe a trauma, maybe somebody that you knew and you saw that in it and it clicked for you.
I think the one thing when it clicked was basically, I in medical school, I was doing a neurosurgery rotation, and we were operating on a pediatric patient, 6-year-old girl with a very large brain tumor in the back of her head, and it can be common in pediatric patients. And she came. I remember she came in basically obtunded. Basically, she had lost consciousness. And they had to act fast. We put a drain in to kind of divert fluid away from where the tumor was. So there's the tumor's blocking fluid basically passing. So we had to put in a drain in the top of her head to divert the fluid, and then she went for urgent surgery within the day to remove the tumor, and then she came out totally fine. And with kids, they are resilient, and that happens. And I think that was the case that really kind of pushed it home that I wanted to do neurosurgery.
Awesome. So you treat a lot of patients now that have been in trauma,
Yes.
correct?
Yeah.
And what are some symptoms that people that are listening out there, and actually, this podcast is for educational purposes only. It is not medical advice, and it does not constitute a doctor-patient relationship. So have to make sure we say that for the lawyers. But going into this now, because we're going to talk about some symptoms, what are some things that if people have, they need to really they need to be seen as soon as possible?
Okay, that's obviously a great question. So, I deal with patients who have been in car accidents, mostly that type of trauma, a lot of times falls, and some other accidents as well, but mostly car accidents. And a lot of times they'll come in afterwards with neck pain or back pain. But what starts to kind of ring alarm bells in a surgeon's head is when that neck pain and back pain is radiating, meaning it's also traveling to the arms or the legs. So usually it's neck pain that travels to the arms, back pain that travels to the legs. A lot of times also they have weakness, numbness, and tingling, decreased sensation in their arms and legs that's associated with either the low back pain or the neck pain.
Right. Great. Wow. So, Alexa, I wanted to ask you a couple things. Now, you have a lot of experience in the industry, in the medical industry, and you've worked in different facets. What do you really enjoy? What's refreshing about working with Dr. Neelan?
Oh, how much time do we have? He hates when I do this
Yeah.
because I love to brag about Dr. Neelan. I've obviously his CV speaks for itself. He has been educated by some of the most high-ended schools across the world, and that has value. But more so than that, as I'm sure you can tell from the stories he's already shared, he's kind. And I think this industry, I think people who are hurting are going through a really trialing time in their life, and they might not even realize it, especially when it's a brain injury and their moods are erratic and they have questions and they don't understand why they're feeling certain ways, why they're acting certain ways. And to sit with a surgeon of his credentialing who takes the time to look them in the eye, to answer their questions, to really care about their life and where they are in that moment and how to make that moment better. Understanding that surgery is a big deal and not everybody wants to sign up for surgery, but what else can we do? How else can we navigate this? And how else can we bring you back to the life that you're used to and comfortable with? And I think it's disheartening that that's so rare in this industry, but it's refreshing to be able to work for and represent a surgeon that brings all that to the table.
Wow.
So it's really an honor to represent Dr. Neelan.
That's great. I know a lot of people out there listening might have been to see a specialist, and sometimes some doctors, they're just so busy and inundated with either administrative work, patients. They have so many different balls up in the air, and sometimes it's hard to keep the patient first and to listen and to have that compassion and care. So that's great. First of all, a lot of people don't know neurosurgeon, it is a very high level specialty. it's rare. There are not a lot of neurosurgeons. There's a lot more orthopedic surgeons. So having someone that cares and is compassionate and listens and addresses people's concern, because it's scary, right? It's scary. What are some misconceptions that people might have about neurosurgery in the spine, let's say?
I think people have generally a misconception that spine surgery and neurosurgery is dangerous. It's not that it's dangerous. It is high risk. Cranial surgery, spine surgery, it's high risk. But it's not dangerous because most of the people doing the surgeries are highly trained and have gone through lots and lots of training to get to where they are and passed lots of bars, lots of tests, and most neurosurgeons are constantly honing their skills. They're constantly learning. We're constantly reading. We're constantly watching lectures, because the learning doesn't stop after medical school or residency or fellowship. You have to it's lifelong learning. Otherwise, and you have to do it. If you don't do it, you're doing a disservice to your patients. So. Right. So patients who are offered spine surgery should do their due diligence about the surgeon, look at his credentials, look at his training, do background checks and make sure they're going into someone with the right hands. But they should also realize that, surgeons at that point who are offering them surgery generally are highly trained and skilled.
Right. Okay. Great. So we're going to elaborate a little bit more on the red flags that somebody, if they are just demonstrating they need or they should seek evaluation as soon as possible. Because I think for a lot of people, that's very, very important, because there are people that just shake things off. They're hurt and they might fall off a roof and they might just think, oh yeah, well, my back hurts a lot and I can't really stand well, but yeah, I'll be okay. Or they get hit in the head and they just might brush it off. So I'd like to talk about both. So if somebody has a head injury, what are some red flags, symptoms that would keep you up at night? So somebody has to come in and get checked.
Okay. So first thing is the mechanism of the injury, correct? So if someone falls off a roof, for example, for like 2 or 3 story house, you should definitely go to the hospital. Okay, and definitely, even if they have like minimal symptoms, just headaches, they should definitely go to the hospital to get checked out.
Right.
Okay. The other red flags, let's just talk about head injury first.
Yeah, we'll talk about that.
Headaches, nausea, dizziness. A big red flag is kind of what we call a interval of clarity and what we call a lucid interval, where you're fine and then all of a sudden you start deteriorating. That's actually a sign for a high pressure bleed, which is called an epidural hematoma. And if you're a family member and you see this happen in a loved one who's had a head trauma, you need to go to the hospital right away. Right. That's very important because that's a surgical emergency.
Right. Okay. And I've watched some football games here and there, and traumatic brain injury, concussions have become on the forefront in the NFL. And I have seen some pretty bad, it seems like bad head injuries, where a player might have a concussion or head impact to the head, and they're wobbly after. Their balance is off. They seem to be disoriented. So those are some things, I guess, that you see. Any other signs that if maybe a spouse or a friend had seen somebody that went through an accident or fall or trauma, that would be a huge red flag?
So lots of things, lots of subtle things like blurry vision, dizziness, persistent nausea, all those symptoms that are persisting after the accident, for a couple of weeks, a month, sometimes 6 months, those are all signs of traumatic brain injury. And in that period, we call it post-concussive syndrome. So all those symptoms are from what I like to call there's the initial insult, which is the impact to the head. And sometimes even in accidents, that isn't an impact. The whiplash type of injury can cause the brain to shift in the skull, and the brain actually bangs against the skull. We call that a coup-counter-coup injury. And even if there's no impact to the head, they can still be suffering from a traumatic brain injury.
Wow. Okay. Yeah. So that's great. So I have educated patients too. They don't necessarily need to hit their head on the floor or into a wall or what have you, and they could still have a concussion because of the brain. I have one right here, going back and forth and hitting inside the skull. that can cause the impact and the insult. So I'll leave this guy right over here unless we want to refer to him later. Yeah, handy to have. So we talked a little bit about head injuries. One other thing, if somebody sees a lot of times in the hospital, they'll check the pupils. They'll shine light in the pupils and so forth. If somebody, not that people should be at home playing, diagnosing certain conditions or trying to do that by any means, but if they notice that one eye was a lot more dilated than another eye,
So that's
speak to that a little bit.
Yeah. So a lot of times people have naturally bigger eyes, one eye bigger than the other. That can happen. But if if one pupil is much larger and non-reactive, we call that colloquially a blown pupil, and that's a sign of brain compression, meaning that the brain. Can I use your?
Yes, please do.
That likely what's happened is there's a what we call a supratentorial bleed. So there's a bleed up here that's pressing down on the brain, and the brain is now pressing on one of the cranial nerves that controls the eye function, and that's causing the one pupil to be what we call a blown pupil, bigger than the other. It's called anisocoria, and usually that's not reactive to light, and that's a sign of brain compression.
Yeah.
And also another sign of a surgical emergency where the bleed or the process that's causing that needs to be taken care of.
Right. So that's a true medical emergency. Now let's talk about spine a little bit. What would be some red flags? Somebody had a severe whiplash, and they're having neck pain. What would be some other red flags where somebody absolutely should get checked?
So let's talk about the neck, the cervical spine first. So neck pain, obviously, but then pain that radiates into your shoulders, down into your arms, numbness and tingling in your arms, your hands, weakness, difficulty with fine motor skills such as opening jars, writing, buttoning shirts. All of these are signs and symptoms of possibly a compression in the spinal cord in your neck, maybe a disc herniation.
Okay. And for the lower back?
Lower back, similar. So back pain that radiates into your legs, usually in a pattern or a certain distribution. Also weakness in the legs, numbness and tingling in the legs. Pain that's worse when standing and walking as opposed to sitting. Sometimes, though, the pain is worse when sitting. It just depends on what's going on. All of these are kind of red flags and signs, especially if it happens after an accident, that something is not right and you need to be evaluated.
Excellent, excellent. I think that we live in a time now where patients are sometimes afraid to go to the hospital, and not so much because they have white coat syndrome. I think because of insurance, sometimes they're worried, they don't want to incur a lot of costs, or there could be other reasons that they want to brush it off because maybe they don't want to admit that something is wrong. I think as guys, sometimes we think we're tough, and if we have an injury, it means we're weak. So it's important if somebody has any of these kind of symptoms to get checked out because it might be something serious. And sometimes people don't realize that if it is a medical emergency, if it's not taken care of, that could mean maybe paralysis, right? That could mean some serious consequences because of not getting checked and seen and taken care of when it could have been taken care of. So very important. Now, with diagnostics, I know that physicians they do an exam. They'll check the patient out. They'll also look at different diagnostics, MRI, CT scans, X-rays. If somebody has a really bad MRI, is that more of what you think neurosurgeons and other spine surgeons go off of? Or how do they use the MRI versus the exam? Could you speak to that a little bit?
Yeah, so that's a really good question because as surgeons, we don't just treat the imaging. So I've seen patients with really bad imaging, but very mild symptoms, meaning they maybe have a big disc herniation in their neck, but they're totally asymptomatic. Or a big disc herniation or a lot of stenosis in their low back. Stenosis meaning narrowing, which is compressing the nerves, but they're asymptomatic. And at the same time, then I've seen patients with less dramatic herniations that are much more symptomatic. So it's very much individually based. And so you have to treat both the clinical exam, the symptoms that the patients are telling you about, and also the imaging findings.
Yeah, and that's actually an interesting point that I thought of while you were saying that, is that somebody might have mild symptoms, and then they get an MRI and they have a herniation, and it's bigger than they thought. And I think that's good. It's not necessarily means maybe that they might not need surgery. I mean, I'm not a neurosurgeon, I'm not a spine surgeon, but I think it's important to watch it because maybe if they get another accident, or maybe if they're doing certain activities, if they're working in a type of occupation that puts a lot of stress on their neck or their back, it can cause that herniation, asymptomatic herniation, to become more pronounced and maybe requiring surgical attention.
Yeah, that's exactly right. Yeah, so you're right. The occupation really depends on. It really depends on your spine. Like your spine health really depends a lot on your occupation. For example, seen patients who are 30 years old who have done mostly manual labor for their life, and they have the spine of a 75-year-old. So very degenerated spine.
Okay. So, and those things, what are, if patients are not needing surgery, it's not an emergency. I actually, and Alexa, I'm going to ask you this too, because you work in the practice and there's multiple different specialties in your practice, right? What are some of the other specialties in SETA Orthopedic Group?
So SETA Orthopedic Group is multidisciplinary. We do have chiropractic offices down in Miami. Locally in Palm Beach County, we have our neurosurgery, spine surgery. We do have extremity surgery, pediatric extremity surgery, which again, when you're dealing with youth and minors, it's kind of a niche and not everybody is able to treat those symptoms. So it's good to be able to offer that. And then pain management for the cases where it's not surgical, but people are in pain, they are symptomatic. And if there's a way to manage that without surgery, then we provide that as well.
Okay, so other options.
Absolutely, yeah.
Now, Dr. Neelan, what are some of the different options that you might recommend to patients that come and see you and they do have, let's say they have a herniated disc in their neck? What are some other options that are common that you or other neurosurgeons would usually recommend before surgery?
Okay, that's a good question. Usually, I see the patients after they've gone through the more conservative management. But generally, if there are some times where I'll see a patient, that hasn't had anything done yet, and usually the way it goes and the way it works in most places is that you don't jump to surgery right away. What you want to do is you want to exhaust the conservative options. They would be physical therapy, chiropractic manipulation, then the next level is what we call pain management. We have a great pain management division, and then we would start with injections, and then if the injections work, we'd proceed to ablations, which ablations are a bit more of a permanent solution, which is like burning the nerve, the pain generators.
Okay.
Yeah.
It's like kind of desensitizing that nerve that's sending the signal to the brain that there's pain in the area.
Exactly. So what we do is we usually do a block first. Our pain management team does a block first on that nerve, meaning injecting medication into that nerve. If that works, that's a sign that that nerve is the pain generator, and then we can do something a bit more permanent like radiofrequency ablation.
Okay, great. All right. So I know you have, I wanted to talk about this next subject because I know you have you've done work with AI and more latest technology with neurosurgery and different technologies that are being used to help patients get better results that are less invasive. I'm excited to learn a little bit more about what's on the horizon and what's impressing you and where do you think things are going to go within the next 4 or 5 years?
So AI is huge, especially in neurosurgery, and anything with a lot of data, it's really big. When I was at Stanford, I was doing research utilizing AI to kind of look at. There's a lot of patient databases out there with patient outcomes, and look at patient outcomes and utilization in spine surgery to see, first thing economically, what's spine surgery costing, and which surgeries are getting the best outcomes. And I think that's really where AI is going. The other area where AI is going into robotics and making surgery safer and better. as far as how we do our surgeries, navigation, making sure we're in the right place. When we're putting in screws and rods into the spine, making sure that the rods and screws are going into the right places and in the right orientation. And all that is just to make surgery safer for the patient.
Question. Now, could AI be used? I guess there's many different ways to do a procedure, a surgery. Uh, would AI be able to model different potential ways to do a procedure based upon anatomical? Now everybody has the same inside. They don't, as much as we look different on the outside, sometimes we look different on the inside. Would it be able to give models or give different or best ways to do the procedure or offer that insight rather than maybe a technique that a surgeon maybe they learned 20 years ago or 10 years ago, but there might be some other techniques that are better for this particular patient because of their anatomy, because of their medical history. Can you speak to that a little bit? Is that happening?
So I don't think that's happening. I think it's going to happen. I think AI is going towards that direction of diagnosis and picking the most appropriate procedure. I still think that you can't beat a trained surgeon's brain as far as like evaluating an individual's anatomy in conjunction with their symptoms, what they do in their daily life, because what they do in their life is also important as far as what kind of intervention you're going to offer them.
Right.
So all of that is multidimensional, and I think AI will eventually get there, but I still think there needs to be a lot of oversight from trained surgeons.
Okay. What about AI in diagnosing?
So I think I'm not as
Aid. I'm not saying. I'm sorry to cut you off, doctor. I'm not saying in place. I'm saying using as a tool.
So patients will go and put their symptoms into ChatGPT and get a diagnosis. That's not gonna. That's
No,
not gonna
no,
change
I'm
it.
not saying
That's
that.
not gonna happen. I think it serves as a good tool because I think it kind of can point patients in the right direction, but there's still a lot of errors in that, and I don't think it doesn't beat going and seeing a neurosurgeon or an orthopedic spine surgeon who's trained. I think that's really, you still need that. You still need the oversight of the AI.
Yeah, I'm more referring to maybe imaging, maybe helping doctors see things because there's so many there's so many different diagnostics, and sometimes to have another set of eyes to see patterns and to see different things, I think could be helpful. I'm not I'm not a surgeon, but I would think that maybe that can help patient outcome with having more sets of data analyzed and being able to have maybe a helper.
And I think you're right about that. And I think I read a study, about a month ago, about radiological imaging and analysis. And so they looked at just AI doing the diagnosis, and then AI with oversight from the radiologist, and then the radiologist alone. And what performed the best was the AI with oversight from the radiologist, then the radiologist alone, and then AI on its alone was far behind those two. So I think AI is important. I don't think it's going to take anyone's job in the near future. I think it's important. I think especially now, it's where it's made the most impact in medicine is on radiology, and I think it's a great tool for radiologists, especially those radiologists who are overworked reading lots of films. They've got that little bit of help, which I think is important. And at the end of the day, it benefits the patient, right?
Excellent. And we also, are there certain cases or certain procedures that you really enjoy doing? That is something that you do a lot of and you enjoy doing, and maybe you've developed a special way to do?
I think that most of the surgeries that especially spine surgeons do are pretty standardized. We have a standardized approach. We all have our favorite procedures. I like doing, my favorite procedures to do are the cervical procedures, the anterior cervical procedures, the disc replacements, and anterior cervical discectomy infusions, which basically involve an incision in the front of the neck, and then getting
this
down.
This is a little bigger than the neck.
Yeah, so that's kind of lumbar spine, but you can use the same principle. Just getting down, you basically make an incision in the front of your neck, and we move some structures aside, and we get down to the disc space. And for diseased discs, we can take them out and replace them with a disc. Now, in some with an artificial disc, which is basically made of metal on the outside and plastic on the inside, and those artificial discs give you the full range of motion as your regular disc would, your biological disc. In some cases with patients with a lot of arthritis, we have to do a fusion, which means that we would put the disc in and then we put screws into both of the bones, the vertebral bodies above and below the disc to stabilize the construct. And that's in the case of arthritis where we have to take off a lot of bone, a lot of the diseased bone as well.
Wow. Okay. Well, great. You know, I am so privileged to have you in the studio and be able to give information to listeners out there, to patients that are scared. They've been hurt, and they don't know, and they're searching for answers. And one other thing that I want to ask you, and some doctors don't like to do this, how do you feel about second opinions?
I think second opinions are extremely important, and I welcome them because you know what? The patient needs to feel confident, right? And so I have no problem with patients going for second opinions. I encourage it when they have any questions or doubts, and if they want to get a second opinion, always happy. And most of the spine surgeons, the neurosurgeons I trained under, were also very much happy for patients to get second opinions. Right. I think it's very important.
Excellent, excellent. It's all about the patient.
Exactly. It really does. That's what it comes down to.
Excellent. So if somebody wants to learn more, they want to get a second opinion or a first opinion, how do they reach you? What would be the best way to reach you, see you, to schedule something?
So we have offices in Miami, Pembroke Pines, and Delray. So getting in touch with any of those offices to see me for a consult is the best way to do it.
Okay, great. And Alexa, too, how do people get in touch with the office? The website and we'll put this also, folks, in the show notes.
SEDAorthopedicgroup.com. You can email me, Alexa at sedahealth.com. I can definitely coordinate an appointment with Dr. Neelan. In listening to you, I applaud you and thank you so much, Dr. Selinger, for having him on and asking such pointed questions because, again, I think it's really important for people to know that not only are they in good hands educationally, but with a good heart as well. And you can tell he takes the time to care and he spends time with the patients, and it's really endearing to see that and to know that still exists in patient care. So SEDAorthopedicgroup.com.
Awesome. Great. And if you are a patient or you're a provider, a lot of chiropractors or other healthcare providers watch our show and listen to us on Spotify and Apple Podcasts. Please feel free to reach out, leave a comment below. Would be more than happy to answer any questions you might have and direct you in the right direction for you to get those concerns addressed. Before we end the show, we have a little routine here, a ritual, where we give away a superhero tumbler. Behind you are all these superhero tumblers. And we do that because, to me, growing up as a kid, superheroes kind of represented comeback, resiliency. And I think we need that more because healing is not just a single event. It takes courage, it takes grit, and it takes that ability to come back and be stronger. And that's what we're about here. So actually both, Alexa, Dr. Neelan, please pick a tumbler. We have Superman, Hulk, Deadpool, Batman, Thor, Captain America, Wonder Woman. Which one speaks out to you?
Let Alexa go first.
Oh, I mean, I feel like the obvious choice would be Wonder Woman, but I'm kind of leaning towards Batman.
Okay.
Because I grew up on Batman, and
he's a fun guy, Batman.
He's something about the bat. So I think I would go with that one.
Okay, great.
As long as Dr. Neelan doesn't want that one.
No, it's fine.
If that was one you're into.
We have another one, Batman. If you would like a Batman, we can get a Batman
Thank you.
too.
This one's Spider-Man?
That is Deadpool, but I do have a Spider-Man back at the office that I can send you, or I can get you if you like Spider-Man.
No, I was just thinking about my son who's 7 years old. He likes Spider-Man, but also likes Superman too.
Yes, Superman. Awesome. So I want to thank you guys for being here today, and I want to thank you for listening. And a lot of people that watch our show, they don't subscribe. They actually watch the content, but they don't subscribe. So if you're out there and you want to learn more and get more information like this, please subscribe to the channel so you get notifications of more videos to come. And again, like, follow, subscribe. See you on the other side.